I'm Peter Block here at the AHA annual meeting in Chicago for On the Scene. And with me is Deepak Bhatt. Deepak does not need any introduction. He's from the Brigham and Women's. Everyone knows him, interventional cardiologist par excellence. Today we're doing a wrap-up, Deepak, of the first day. And interestingly, for interventionalists, there are 4 trials. And I always forget the names, so I'm going to read them. DAP trial, the ISR SAFE, the ITALIC trial, and then we'll throw in a prasugrel trial just for the sake of discussion at the end, because it is a little different, but nevertheless. So let's paint with a broad brush, Deepak. These trials, in general, teach us, I'm going to say, not an awful lot. And then I'm going to throw it back to you and say, tell me what you learned, because I'm not sure I learned a lot from this.
Sure. Well, as a trialist, I think every trial helps inform us, and these were 4 well-done studies. There was a very large DAP trial examining 12 versus 30 months of dual antiplatelet therapy in stented patients. There was ISR SAFE that examined 6 versus 12 months, ITALIC that examined 6 versus 24 months, and then another study that was really part of the DAP trial, a sub-study of it examining paclitaxel-eluting stents and 12 versus 30 months with prasugrel.
Right.
So 4 different designs, lots of subtleties and differences between them. One of the trials ended early because of recruitment issues. Another one also didn't have quite the event rate that was anticipated. So some limitations in really assessing that overall data set. But I think some themes that do come out of examining all 4 trials together.
Okay, but I think it's also important to say that if you took each individual trial, there are very small subsets that are positive. So let's go into that a little bit. In general, not a lot of difference between the control or the 2 different kinds of groups in all of these trials. What do you take home from this? As an interventionalist, what do you learn about the specifics? Stent thrombosis is obviously still around to bother us late.
That's right.
These folks come off their dual antiplatelet therapy in these trials. They end up having an increase in events, and that's probably due to stent thrombosis in those stents that tend to have that, the paclitaxel-eluting
Absolutely.
stents.
So there's a difference in stents. The paclitaxel-eluting first-generation drug-eluting stent for sure has a higher rate of very late stent thrombosis than the second-generation DS, which seem to have very low rates of stent thrombosis. So I think the absolute benefit in terms of longer durations of DAP depends on the type of stent, depends on the type of patient, an ACS versus non-ACS patient. May depend on lesion-specific characteristics, depends on the patient's bleeding risk. If somebody's a bleeder, long-term DAP, probably not a good idea. So I think what we're really left with is that the duration of DAP needs to be individualized based on the patient, and that's a message not just to interventionalists, but also to non-interventionalists.
Yeah, I think you're right on target there, Deepak. I think that if you take all of this information and sort of winnow it down to the important nuts and bolts, that it has to do with choosing your patient's risk factors and then making decisions about how long you continue your dual antiplatelet therapy on the basis of what their risk is. If they're diabetic or pre-diabetic, if they have severe hypertension, if they have a bleeding problem, I think that all changes the dynamic, doesn't it?
I think so, and it has to be a dynamic process as well. During that first year of guideline recommended DAPT, if the patient's having lots of bleeding, probably not a good idea to continue longer. On the other hand, if they've already had a recurrent event that first year, I don't know that I'd stop at 1 year. So I think it really has to be a very thoughtful decision on the physician's part, very individualized for the patient, sort of the art of medicine more so than pure science saying you have to go this long.
I'm going to throw one of your trials back at you, the optimized trial, which was now about a year ago.
Right.
And in that trial, it was 3 months versus a year of dual antiplatelet therapy, no significant difference. But as you point out, and as I would point out, those would be the patients that I would choose for only 3 months who have really a low risk.
Right, and there if they've got high bleeding risk in particular, I think you've got an out if you want to just go 3 months. And the European labeling does allow for various second-generation DS, 3 and even 1 month of DAPT. That's not the case in the U.S. So I think the flexibility to individualize based on patients' ischemic and bleeding risk, going really short if you have to, and going long-term if it seems indicated based on ischemic risk, including what events may have occurred in the first year, I think that's the way to go. But I'll also point out there are other trials that are ongoing that will further inform us.
The dual antiplatelet business is still not dead, is it, Deepak?
It's the gift that keeps on giving.
There you go. Thanks very much.
Thank you.